Okay, let me just introduce myself for those who don't know. My name is Stephanie Garty. I was a former Chief Pharmaceutical Officer's Clinical Fellow from the Transformation Directorate within the Digital and Interoperable Medicines team within the Transformation Directorate in NHS England. And this is the ePrescribing Masterclass that we hold monthly. We didn't have a session last month due to the Queen's death, but we've got another session today for October's ePrescribing Masterclass. Can I please implore everyone, if you are on social media, whether you've got Twitter or LinkedIn, could you please talk about the session and hashtag ePrescribing Masterclass. Okay, so I'll just wait another minute and then we'll get started. Wait for everyone to come in. I think we'll get started with this month's session, just because I'm mindful we've got quite a packed agenda, and I know you want to hear from all the different speakers today. So I will introduce our first speaker, who is Pauline Lockley, who is a patient safety lead, clinical lead, and medication safety within NHS England, and she's going to give us an update on the reported safety incidents and just give us some food for thought of incidents that have been reported. So I'll hand over to Pauline.
Thank you, Steph. And as Steph said, my name is Pauline. I'm a pharmacist. I work in the National Patient Safety Team, and my remit is to look at new and under-recognised issues. So what I am not going to do, we'll talk about the big things that we all know, the opioids, the anticoagulants, the incident kind of risks. We look for perhaps new things that perhaps haven't been seen, or perhaps are bubbling up, and we need to kind of capture them and see what we can do about them in the earlier stages. We do have a statutory responsibility to look for these things, and part of our role as well is to ensure that the system is provided with some advice and guidance to try and reduce the likelihood of recurrence of those sorts of events. The primary source of a lot of our information is the National Reporting and Learning System, but by no means is that the only source, and I think you'll see from some of the incidents that I share that we do get triggers from a number of different places. And in terms of, sorry, the next slide, please. Yeah, and in terms of where we look for in terms of developing advice and guidance, it doesn't sit with us to do the actual guidance writing. We really look to work with others in a collaborative way to identify who would be best placed to develop the relevant guidance. So the sort of people we would work with are the Royal Colleges, it might be some of the arm's length bodies. We do a lot of work from a medicine safety point of view with the MHRA. We've got good links with the editorial board at the BNF. We work very closely with the Medicines Use and Safety team at Specialist Pharmacy Services, and often we work through that sort of level in order to bring about some of the changes that we would advise. Occasionally, some of the issues we identify are of the significant concern, or they meet certain criteria, and they are quite strict criteria, and if they do, we would then issue a National Patient Safety Alert. The purpose of today really is to bring some of the issues that we've already looked at and share with you some of this sort of level of collaborative work that we've done with some of the other bodies. And they are parts of the jigsaw that we've put into place. But as you know, there's no one-size-fits-all solution for the sorts of issues we're looking at. So really, we're just trying to sort of ask, how can we put another bit of the jigsaw in place to increase the number of patient safety strategies that are in place to improve the offering around the issues that we're looking at. And what we will recognise, and I know that you will, is that these won't sit with you alone. You would need to do some close working with people back in your organisations, medication safety officers, patient safety specialists, in order to agree how to take the issues forward. Have the next slide, please. So the first issue that I'd like to highlight relates to high-dose vitamin D preparations, and it's particularly how these are prescribed and administered. We became aware of this issue following media coverage of a coroner's report. It was a very sad case. It related to a patient with vascular dementia. She was prescribed initially a low-dose cholecalciferol with the intention to give this twice a month. And for a short while, as we understand it, that is how she took it. However, she subsequently moved to a care home where a different GP took on her care. And the information that was added to the system there was to take 2 tablets, but there was no clarification about the intended frequency. As a result, the patient took 40,000 units of cholecalciferol every day for approximately 5 months, and was subsequently admitted to hospital because of raised calcium levels and the symptoms that she was exhibiting. And sadly, she died as a result of the intestinal bleeding that developed, which was attributed to the elevated levels of vitamin D. And it was the coroner who investigated that and said that we needed to look at this in a different way. We looked into the NRLS to see if this was a one-off or if there were more examples, and we found quite a lot of concerns relating to the use of these preparations. One of the key things related to the frequency. Quite often it's intended to be taken either weekly or monthly, but we saw a number of examples where that frequency wasn't correct, and the most common being that it was prescribed as a daily dose, and it might have been administered as a daily dose or dispensed. So there was elements at all stages of the prescription journey where the errors happened. We also saw examples where the loading dose regimen was exceeded. The normal regimens, they can be varied, and there can be differences in the duration. Usually it's sort of 6 to 10 weeks you would give the treatment, but the maximum threshold would be 300,000 international units. And we saw examples where that total dose had been exceeded. And we also saw examples where the loading regimen had been started in an acute setting and inadvertently had been continued as part of the transfer of information to primary care. It had been added to the repeat prescription, and the patients had continued to take these very high dose preparations following transition to their home base. I put a little bit of background there, which I'm sure you're familiar with, about the differences between the loading dose and the maintenance therapies, but we'll give you that information for your use to read later. If I could have the next slide, please. So what have we done about this issue? To date, we've shared it with a lot of the different groups that I mentioned at the beginning. And one of the key teams that have worked very closely with us on this have been the Medicines Use and Safety team at Specialist Pharmacy Services. I've put a hyperlink to the publication that they produced, which was published in September. And basically, this is outlining a lot of the risks that I've just highlighted, a lot of the concerns, and some mitigations that could be considered to reduce the likelihood of occurrence. So it's a very valuable resource that you might find helpful when you take this issue forward. We've also worked with the BNF, who at the time of writing the slide had amended the information relating to the dose. They've also just updated today, or confirmed today, that they're also adding information about split dose regimes, intermittent dosing, and loading dose regimens. So that will be available in the online publication next month, and then obviously in the printed version when it's next out. You can see there as well, we've done quite a bit of work with the MHRA and asking them to influence manufacturers with regard to this information. The challenge really for the people listening today is, what else can we do? We need to add another bit into that jigsaw about the electronic systems, and how can we ensure that we've got clear documentation relating to the indication, what is the intended dose, what's the intended frequency, and how is that information captured at the point of prescribing as well as at transfers of care. Is there a local formulary agreed? And if so, how is that linked into the trust system? Because there are different loading dose regimens, and that's part of the complexity of the story. So really the starting point is a local agreement, and then making sure that that's what's actually incorporated into the prescribing systems. Is it possible to force a requirement to specify the intended duration or include a stop date at the point of prescribing? And then the other element is at the dispensing stage, because if we've actually got it right at the prescribing stage, but then inadvertently we put the wrong frequency, for example, on the dispensing label, we still perpetuate the risk that the patient can take it at the wrong frequency. Could I have the next slide, please? So what I've got in the next couple of slides is an example of some work that was shared by the team at Bolton. So if there is anybody on the call from Bolton, thank you very much for the sharing of these. This came via Ribble Ahmed, who's the Medication Safety Officer at Bolton. And he shared this work at the Medication Safety Officer Network update last month. And what he was doing was showing what he'd done in terms of electronic solutions to some of the issues that we'd identified. Their starting point was that they agreed a local guideline in their area for the use of high dose preparations. And you can see on the bottom left-hand side there that there's a link on their system to these guidelines. The guidelines stipulate what they recommend as their loading dose, and that is automatically populated in terms of the loading dose. And you can see for this example, it's a 40,000 unit dose. They've also removed the daily option. You can see on the right hand side, and they've only got weekly options available for selection because that is their loading dose agreement. And they've also forced a entry there to say the limitation on the number of doses. So in this case, you've got a link of 7 doses. So the patient will take 40,000 units on a weekly basis for 7 weeks, which would be the correct sort of dose for their agreement. If we could have the next slide. And the other piece of work that they've done is to look at their ascribed templates, and again, to reduce the likelihood of sort of perpetuating an issue when it is dispensed. They've actually looked at their templates on Ascribe and have incorporated their locally agreed frequencies for the specific formulations of vitamin D that they use. They've removed the option for a daily dose, and they've only got weekly dose options. They've added warnings to the Ascribe system to flag if cholecalciferol is prescribed outside of the usual range, and they've also included information to remind the prescribing team and the dispensing team that the maximum dose is 300,000 units when you're using a loading dose regimen. Have the next slide, please. Thank you. So the second incident, or the second issue really, that I'd like to highlight relates to the use of calcium or phosphate electrolyte replacement therapy when you're using effervescent tablets. And the trigger that came to us in this case related to use in a child, a very young baby, and the parents were not given clear information, either via the dispensing label or at discharge in terms of written information potentially, how to prescribe the prescribed dose of phosphate using effervescent tablets. As a result, the parents gave the baby 3 doses of the total volume in which the whole tablet had been dissolved, instead of the intended part volume. So each dose that the child got was 16 times higher than the intended dose, and they got 3 doses. The baby developed hypocalcemic seizures, required admission to hospital where they had a further seizure, and took some time to get their condition under control. And in terms of the additional information at the back on the right-hand side there, you can see that if you're going to use a licensed preparation to provide a source of phosphate or calcium in an oral solution, then the only option you have is to use the effervescent tablet formulation. So this is quite a challenge because as we know, quite a lot of complex information to try and get into a prescribing or an administration system. The information needs to be complete, it needs to be accurate, but it also needs to say how much of the tablet to use, what volume of diluent to use, and how much of that prepared diluent to draw up. So that's quite a complex story to communicate in an electronic format. So there's a challenge. We did look into the NRLS, and we did find that this was quite a common issue, and we saw a number of examples where young babies and young children were being given significantly higher doses than intended because we were giving the whole tablet equivalent of that dose rather than the part dose that was intended. So some of the strategies and actions that we've taken, we've again worked with the BMF. They are reviewing their information, but that hasn't been updated as yet. NPPG, that's the Neonatal Pediatric Pharmacist Group, are looking at this as a wider piece of work. They're going to develop a position statement and also supporting us with taking some of the concerns forward. And in terms of resources for parents, the Medicines for Children leaflets are being revised to update that information. But this really is a challenge now. How do we make sure that for an electronic system, those effervescent tablets are prescribed and administered with that complex information as clearly as possible? I don't have the solution, but I'm hoping that if you do have anything in place in your organisations, or if you can think of a way, that this is something that you could share with us. Are there templates that you could use? Is there a formulary set that could be, or a protocol that could be supporting the information? And also, how do we get that information onto a dispensing label, or do we have to give some supplementary written information? And if so, how do we ensure that that's communicated to the parents? So that's really the challenge that I'm throwing out, and I'm sorry I don't have the solution. Could I have the final slide, please? Thank you. And so this is the third issue that I just wanted to share with you today. And this one relates to the use of betamethasone tablets and using them as a mouthwash. In this case, the tablets were prescribed and intended to be used as a mouthwash. However, the patient didn't realise that and swallowed the tablet 4 times a day and subsequently had an adrenal crisis. And it's not entirely surprising that this happened when you realise that whilst the 500 microgram soluble tablets are known to be used in this way, in fact, it's kind of well documented practice both in the BMF and in some of the NICE guidance, such as the clinical knowledge summary for the management of ulcers, for mouth ulcers, that is. We are aware that if you don't give sufficient information to clarify the intended use as a mouthwash, there is a risk that the patient could swallow this preparation. The patient information leaflet doesn't support it because it's an off-label use, so the information that the patient has in their hand would suggest swallowing the tablet. So we're kind of not helping the patient here. And it's my understanding that EPMA systems use the manufacturer's data to sort of automatically populate the prescribing and dispensing fields. I appreciate that's your area of expertise, but that's what I'm sort of aware in my thinking. So when a medicine is used off-label, that formulation and the different use, mouthwash, for example, preparation, wouldn't automatically appear as an option when prescribers or staff come to administer the medication. So it might not be something that's readily available and not obvious to see. In terms of what we have done, the BNF and the NICE clinical knowledge summary have been updated to include information reminding people not to swallow it, but of course that's not really reaching the patient. And again, SPS have produced a helpful comprehensive issue there that you can see the link to, outlining the risks and some of the mitigations. But the challenge, again, looking back at our sort of how do we add to the jigsaw, is what can we do to make sure that this off-label use and the risks of swallowing this preparation are highlighted? Can we put mouthwash in as an option on our electronic system so that people can actually choose that, which, as I say, it isn't there at the moment. That's my session over, and if there's anybody got any questions or anything, I'm happy to try and take those. Thank you.
Thank you, Pauline. That was really great, and given, I think, a lot of us food for thought about lesser used preparations and thinking about mouthwashes and thinking about vitamin D as well. So I think lots of food for thought for people to go back and check their systems. So there was a couple of questions in the chat. So we have one about, does the National Patient Safety Team look at the clinical decision support tools and whether and how vendors or suppliers trigger alerts? Is that something that we look at within the team?
Within our small team, no, I don't think that is. Yeah. That's something that maybe we need to consider, but no, it isn't. But I can certainly take that back and find out whether it is something that we should be, certainly with regard to maybe some of our patient safety alerts, etc. But no, at the moment, that isn't something that we've done.
And how does the team interact with, say, digital safety officers? And is there much interaction between yourselves and the National Digital Safety Team?
I don't think there's an awful lot, but we do have a regular forum where we bring the concerns when we first identify them, and we're really exploring, are these a concern? It's an internal meeting, but it does have quite a broad attendee, and there are some of the team come to that, and it's very helpful. They've only been coming for a short few months, I think, but it's really transformed the way we question things and looks at, because what we don't do at that point is try and identify a solution. We try and ask the question, is it a problem? If it's a problem, shall we look at it further? And then when we bring back a review, we will begin to explore what options and which groups should we be working with. And we often have some very good, insightful advice then from colleagues from the NHS Digital Line.
That's great. And then can I just ask one final question? What do you think people who are listening today, what should they take away in terms of medication safety? What would you like them to take away and to think about?
I think that there's a few things. One is that you've got a medication safety officer in your organisation. I think we should be working very, very closely with them because, as I've said, I don't think there is an easy solution to any of the issues that we identify. Everything that we do relates to medicine safety, whether we're buying it, procuring medicine, when we're putting something new into a formulary, it underpins everything we do. I think we should be working really closely with our medication safety officer team, but also appreciating that we're not looking for a radical solution that will prevent everything. We're looking for a little bit of the work that will help to add to the jigsaw, because we can't prevent these things always, but we can always reduce the likelihood of them happening. And it's about reducing the risk rather than abolishing it. So even small actions are welcome and good, and not trying to make it too big sometimes.
That's great. Thank you, Pauline. And thank you for your presentation, answering these questions.
Thank you.
If anyone does have any more questions, please leave them in the chat, and we'll try to aim to answer them afterward, after the session. Thank you. Okay, so I'm going to hand over to our next speaker, which is Dr. Claire Tolley, who is a lecturer at the School of Pharmacy at Newcastle University, and she's going to give us a talk about digital tools and medicines optimization. Hi, Claire.
Hi everyone, thank you for inviting me to speak today. So I'm going to talk a little bit about a project that we ran that was derived from the AHSN and the Digital Primary First Transformation Group as well. So this work was done in collaboration with Helen Seymour and Dave Belshaw. Next slide, please. And sorry, you can do a few clicks now. that one's perfect, thank you. Okay, so I guess to give you a little bit of a background to this project, as you're all probably very aware, we know that transitions in care are particularly error prone, and they're associated with lots of unintended changes to medicines. This can cause medication errors and miscommunication as well. So the situation can be quite messy for patients, but also healthcare professionals as well. So what we wanted to do within this piece of work, if you can just click, please, on the screen, and oh, that's worked, but or not worked. But anyway, what we wanted to do within this piece of work was to engage with key medicines optimization and IT stakeholders across the North East and North Cumbria integrated care system. And we wanted to scope out a little bit about what systems were being used to transfer information across interfaces of care. And we wanted to look at kind of what the challenges were, what the potential opportunities for more effective cross-sector working were. So this was the piece of work that I'll talk to you about today. Next slide, please. So we did a qualitative piece of work led by Newcastle University, and we conducted 22 semi-structured interviews between January and March of this year, and they were all quite in-depth, usually lasting about 1 hour, so it was quite in-depth and lengthy discussions I had with individuals. So I spoke to lots of pharmacists with a pretty broad coverage across sectors, so 19 pharmacists, and that was split between community, hospital, primary care sectors, and also NIAS as well, and NHS England and NHS Improvement. And I also spoke to a couple of GPs as well. And I explored the perspectives of these stakeholders around the current medicines optimization services and what digital tools were used to support this process and the flow of information. And then I analysed it kind of in depth by going through all of the comments and the interviews from participants and looking for kind of the key themes and key areas that we can learn from. Next slide, please. So what I was able to do as part of this was almost come up with a map of some of the systems that are used in the area, and this is hold my hand up, it's not comprehensive, so it's not meant to be an accurate representation of absolutely everything that's going on. But I think what I picked up from the individuals that I spoke to and from looking at some of the different systems that are used is that there's a lot of them, and the whole link of systems is the way that systems interact with each other is very complicated as well. So there's a big reliance on kind of bespoke arrangements to have communication between systems. Sometimes we're transmitting information through NHS mail, maybe it's through phone or GP Connect. We've got some bespoke platforms that have been built and designed to send referrals for information, for example, from hospitals back into community pharmacy, for example. And it was quite interesting doing this piece of work, and it was quite enlightening to see the range of different systems that are used across different areas. So lots of different systems in primary care, secondary care, and then when it comes to social care, the picture is very much still largely paper-based. So the majority of stuff is still on paper records there as well. So again, that stood out to me as quite important. Next slide, please. So what did I uncover then in terms of the transfer of care issues? And I think what people were generally telling me was that there's a real issue with having incomplete patient records when it came to optimizing individuals' medicines. And this was down to the fact that data was held in silos, it was very separate. There was ineffective data flow between individual systems, and this had an impact on reducing the efficiency of their day-to-day work, and then importantly, reduced safety as well. And I'll talk in the next slide, please, of an example that really resonated with me. So I'm not going to read every quote out, but I do think this this one was quite a good example. So one pharmacist mentioned to me that around the issue of incomplete patient records, that you get different teams going into homes, and the different teams have access to different kit and caboodle. The district nurses tend to have part and parcel of either a community trust or a GP practice, but they don't tend to have support for the work that they're doing. If you've got carers coming in from a private organisation, they may or may not have access to the same kit. And I'll use an example. A patient was discharged from hospital. 2 levels of care were being provided, and this was in a palliative care scenario. So carers were coming in to provide the social care bit and some medicines administration, and they had their own IT. But because they weren't qualified healthcare staff, so they weren't nurses, they didn't have instructions to what they do, and they couldn't do anything without it. And they had IT that wasn't keeping up with the speed of changes to the patient's prescription. And this was a problem because the care staff wanted to administer medicines because they were being told to by the software, yet the family knew that this was no longer the current prescription. But the care staff couldn't administer the new prescription because they didn't have all the information to do it as well. And then on top of that, the district nurses didn't have access to the system that the carers were using, and they were working to a different prescription again. And in this one kind of vignette, this one little scenario that came from one pharmacist, I thought it totally encompassed many of the issues that I know we face day in, day out in practice. Next slide, please. There's probably a little bit of clicking through things. Just keep going, sorry. Lovely, thank you. So one of the next themes that came out of this piece of work was the fact that we have so many different systems in place, and this had an impact on individuals' workflow. So participants described how the sheer number of different systems that they had to interact with on a daily basis. So for example, it might have been appointment booking systems, referral systems, labelling systems within a pharmacy, patient records systems as well, all played a huge cognitive burden on them. And while you're having to compute and navigate between different systems and platforms, there's a safety issue related to this as well. Next slide, please. Next, we identified many issues relating to interoperability between systems and the knock-on impact of this on patient safety. And one example that really stuck with me actually is where a GP described how the community nurses that were affiliated with their practice and who were visiting their patients couldn't actually access the same GP record that the practice-based staff could. So they were prescribing medicines or reviewing patients in the community, but they couldn't see the same information or in the same way that the GP could. It may have been that they didn't see the blood test results, for example, or the most up-to-date version of the blood tests in the same way without having to navigate through multiple different systems. And this was a problem because all of that information wasn't flowing into one kind of truth of one system. All of the benefits of clinical decision support tools, for example, that can do interaction checking or can maybe cross-reference against renal function, for example, wasn't being given the chance to work optimally. Next slide, please. Then through this work, we also found an example of is what I've kind of termed as digital gaps or blind spots in the system. So what we found here was that there was certain pieces of information, clinical information, that was still documented in paper. And they thought this couldn't kind of automatically feed into some of the shared care record initiatives that are ongoing, and therefore this limited the benefit of this shared care tool, of these shared care tools. And I think this also highlighted a further interesting effect as well, whereby you had organisations that were less digitally advanced, and they were falling further behind because then they couldn't utilise some of the benefits of the regional digital tools. So there was kind of inequities that were seen as well. Next slide, please. Okay, and then the next thing we uncovered in terms of another key theme were some concerns raised about how systems were managed. And participants described kind of this proliferation of numerous systems or numerous solutions to address problems in isolation. And there was definitely the potential and actually evidence of duplication, and this also had a duplication in terms of the way things were done, but also costs and the resources used. And definitely a feeling that there was reinventing the wheel lots of the time in terms of services and tools that were being developed. And they also kind of highlighted the need that standards were really important around this, and so there should be more standards that mandate that kind of minimal functional requirements of systems from commercial system providers, for example, saying that this is what the outcome needs to be, and the system needs to be able to do that. Next slide, please. And then finally, but very, very importantly, participants described how one of the key aspects to utilising digital tools in medicines optimisation was actually winning over people's hearts and minds. And it was acknowledged that some of the technical work has already been done, and there's certain standards that are out there, for example, medication terminology standards to be used in the NHS. But the profession needs to kind of adopt these and win over the profession in certain circumstances as well. Next slide, please. Okay, so to finish with, I'm going to touch on, I had this lovely blue sky question at the end of my interview. So I asked, what do you want for the future? What kind of things would you like to see moving forward? And this is another quote that I'm going to pick out because I think it really summed up what the views of a lot of participants. And they said that they wanted one record across all organisations. That's the blue sky thinking. The data would sit in a data repository that would be coded and accessible via APIs, via front-end systems that be customised to be targeted to how GPs work, targeted to how secondary care clinicians work, targeted for acute and outpatient mental health. Fundamentally, all the data would be held in one central repository for that patient, and all the systems can pull in that data. And that, I think, kind of encompassed a lot of the general themes and hopes of individuals. So just to finish with, I'm on the next slide, please. We need to think about how we're going to achieve this. And I think there's many different ways that this could be done, but the priorities and where do you start is kind of important. So I think there's certainly something about adopting the medication standards and digital infrastructure across regions and across sectors. There's also something about making sure that community pharmacy and all sectors are involved and equipped with the right information to explore, how community pharmacy can get involved with things like the Great North Care Record in the North East. Is important, and the list could go on. There's things around population health, systems management, what's the vision for pharmacy, etc. So there's lots of more work to be done in here. I'll end there, but on the next slide, I'm very interested on what you guys think as well, and your thoughts on maybe the priorities or where we can go with this. Thank you.
Thank you, Claire. That was really insightful, and lots of food for thought and things about the importance of interoperability and having that blue sky thinking and having that one record. So one of the questions in the chat was, what do you think and what's your opinion on the interoperability standards? Do you think it will improve things, or do we think there's much more further that we can go with it?
So that I just cut off a little bit there. So in terms of the interoperability, oh no, is this just me? It's cut off.
No, can you hear me now?
I can. Sorry, Steph, it's frozen for me.
Oh, can you hear me now? Is it not frozen?
Your face is, but I can hear you. So
Okay, we'll go with that. And I was going to say, do you think that the interoperability standards will improve some of the things that the lack of transfer of care, and what do you think about the time frame, and how long do you think it will be before we see some benefits?
I mean, I absolutely think the vision is that it should improve things. If all systems are sort of, so to speak, very simplistically speaking the same language, then that's definitely going to improve things in terms of the transfer of information across care settings, which I think is integral to a lot of the problems that you do see. But I think there's a huge challenge in terms of organisations adopting this, and I think we're coming out of a period of, COVID and huge demands on the healthcare system as a whole. So the timeline is hard, and I think it's going to be this journey. I think there will be, organisations that get there sooner than others, but there's probably a bit of noise to be made, I suppose, about the benefits of this, and putting it higher on that priority list of a whole host of other really important priorities, and that's the challenge, I think, within individual organisations. So yeah, I think it's a huge challenge. I don't necessarily think it will all be done by the deadline. I know it's coming up kind of in 2023, isn't it, for adoption of these standards. But I think we can be real about that, and we can say that there are quite a lot of barriers to it. But we do need to start kind of nationally, I think, really putting forward the benefits of adopting, and how this can really help some of the way that we want to improve things, because I think it can be quite huge.
No. Yeah, I think it is, but I think having the standards there in the first place is a step in the right direction. And yeah, without them, I think it may be a little bit lost. I think in terms of one of the other questions I wanted to ask is about, there was a few trusts and companies that you'd said were not so digitally mature. How do we push them forward in order to push this interoperability forward? What was your opinion on that?
Yeah, so I think one of the things actually is that so for some organisations, they at this point may not have even electronic prescribing systems in place. So that's where it kind of it can start right at that very beginning level. The good thing is now that we've got these standards, those organisations kind of are coming from, they can move forward very quickly and learn from all of the other sites, but they can do things in the right way. And actually, there's huge scope there for them to be running very quickly, if you like, going from walking to running very quickly. And actually, in some ways, those that have got quite established systems, but perhaps they've been built in, a way that where old standards are used, it's actually sometimes there's a big challenge around unpicking that and adopting new standards. So I don't necessarily think that it's just a case for bringing forward those that are just starting the journey either.
And what do you think, and this is probably going to be my last question, and what is the key takeaway for everyone that's here and today? What would you want everyone to work on with all the things that you've taken away speaking to lots of different people?
Oh, that's a very good question. So I think probably my last slide actually is a bit of my kind of my headspace actually, in terms of what I think are the take-home messages. I think there's a lot to be done around adopting what we've got out there. So where there are standards, where there are kind of messages about doing things in an established and standardized way, I think we should be thinking strongly about prioritizing that. I also think there's lots of gaps in the system, so around community pharmacy, around social care as well, and I think we need to start filling those in for the whole system to work better. And I think we're going to be managing patients less in silos now, so we should try to get the information all together, and we're only going to be able to do that if we bring community pharmacy into the arena, mental health, social care, etc. And then I think once you do that, then there's the whole host of opportunities in terms of what can pharmacy deliver, what can you do from a population health management perspective, and kind of all the exciting innovative stuff as well. So I think there's some practical things where we need to focus on and knuckle down, and then we can kind of get really carried away with all the exciting things that can do things on a big scale.
No, that's great. Thank you. And thank you, Claire. So I'm going to quickly go to our next speaker. So our next speaker is Angela Virgin. She is a former HEE Clinical Leadership Fellow, but now is HEE NIHR Clinical Directoral Research Fellow within Leeds Teaching Hospital. So I'll hand over to Angela.
Angela, we can't hear you. Can you click mute and unmute again?
I'm so sorry.
Yeah, that's working now. Yeah.
Is that working now? Can you hear me?
Yeah,
I don't know what's going on.
Great.
I live in a valley.
Great.
It's probably to do with that. Digital transformation at its finest. Anyway, I'll start again. So sorry. Yeah, I was saying that I undertook a clinical leadership fellow last year, and it ended in July this year. And during that leadership year, did a project around digital skill development of pharmacy workforce. So I've tried to pick the highlights to share with you today, and hopefully it will, I suppose, it is mainly the headlines, I think. So there is an exec summary and a report. So if more information is needed or people want to hear more, then there'll be more information to follow. So in terms of digital skills, next slide, please. I suppose it's probably important just to define what I mean by that. So I'm talking about staff having the confidence, competence and capability to use digital systems. And it was all around providing the best patient care and improving patient outcomes. Next slide, please. So the aims of the project were to identify the real-world barriers and facilitators that pharmacy staff were facing when it came to developing that digital knowledge and skill set. And from that, I really wanted to create some recommendations that would really support and enable staff to develop digital skills. And I suppose it was all about the greater good of fully realising the potential of digital system use in healthcare. Next slide, please. And in terms of the where and the how, I was really keen. My background's in hospital, so I've worked in secondary care for just over 20 years, and the last 6 or 7 years has been within an EPMA implementation team. So I have lots of experience in that. So I was really keen, I suppose, to go further and a bit beyond that. So I was really fortunate to be able to recruit staff across an ICP footprint. And part of the idea was that around, I suppose, the advent of the ICSs and trying to understand the challenges that our colleagues in pharmacy across sectors were facing. So I recruited staff of all levels, from secondary care, mental health, from primary care in the CCG, PCN and GP confed teams, and also in community pharmacy. And I was really keen to hear from senior leadership in each of the sectors, but also frontline working staff. And it was quite interesting listening to both groups of staff. And in terms of how I collected the data, I started out by undertaking focus groups and semi-structured interviews, depending on people's availability, because it was really hard to try and get people in the same virtual room. But I really struggled to recruit frontline staff from primary care and also community pharmacy. So I managed to speak to almost 30 pharmacy teams. So that included pharmacists, technicians, and some assistants and healthcare workers from pharmacy. But to collect some data from primary care and community, I designed a questionnaire and managed to get a response rate of about 75 participants through that. So I ended up with quite a large data set in the end, which was very interesting. Next slide, please. So the themes that came out from the data, next slide, please. As I say, quite a varied and wide data set. There were 7 key themes. So the first one, people talked a lot about their digital knowledge and skill development and how they got to where they were today. There was a lot of talk around change and supporting staff with change. Lots of staff talked about innovation, and I'll talk a bit more about that. But also one of the key things that came out across all groups were the perceived risks associated with staff not developing their digital skills and what that meant for them as individuals and patients. Staff talked quite a bit about technology itself as the barrier to digital enablement, and Claire's obviously spoken about that, so I won't talk about that here. It didn't go in as much depth, but it certainly touched on, and there was a lot of reference to that. And there were some interesting points that came out in and around the leadership required, in and around digital skills and digital support, and what people felt was needed and what had worked well. And I think one of the key things, and what was really interesting in terms of collecting data from across an ICS, was in and around, I suppose, the wider healthcare system. And what I was really fortunate to recruit some staff that had worked in different organisations within the patch. So it was really interesting to hear their experiences, and also to get some information and feedback in and around what might help and work better. But that will come out shortly. So I think probably just to say that I'm not able to talk about all of this today, but the top 3 themes are probably core to the rest of it, so I was going to focus on those today. Next slide, please. But before I did do that, I suppose I just wanted to share, and I think for me this project really opened my eyes more than they already were to the risks of us not investing or not supporting staff, certainly in terms of developing their digital skills. It became very clear very quickly that all staff said that they felt they weren't using systems to their full potential, and staff expressed, I suppose, concern at the waste of that in terms of the investment and money and time that's going into digital system and implementation across healthcare. So that seemed a waste, but equally, I suppose, the risks that come with not doing that to patients and to the care that we deliver. So that was really heavily felt by staff. And expressed as a real concern. And I think the other thing that came out, particularly across this wider healthcare system, people talked about having commonality in system but not in system use, so they were actual words of the participants. So this is the idea of organisations may use the same system, but the way that that system is configured or set up, and certainly maybe the access or the user rights that individual staff have, may be different between organisations. So this is an ePrescribing Masterclass, so if we use electronic prescribing as an example, what that effectively meant was that when staff moved between organisations, that change in system setup meant that their roles changed, and equally it also meant that the use of the system changed, and it was harder. People talked about there being holes in the system that could cause risk to patients, so they might have learned what that was and how they could increase safety with system use, and when they moved, that almost that safety net or that knowledge had changed, and how do they learn that, and that was something that was considered quite important. So yeah, risk to patients. People talked about poor digital skill set hindering innovation, and that's well known. You know, we can't really fully realise transformation if staff aren't fully equipped with the skills. And then also staff felt and talked a lot about frustration and dissatisfaction, because they couldn't use the systems as well as they ought. And there's also this risk, I suppose, of burnout, because what happens is that staff carry on working with old ways alongside the new ways with the digital systems, and to work in that way isn't efficient and can obviously be quite tiring and frustrating. So yeah, it was just quite an interesting point, I suppose. Next slide, please. So just to talk a little around the first theme of digital knowledge and skill development. So as I say, staff talked quite a little bit about only skimming the surface of digital system use. and obviously the implications and how that felt for them. And even when they said they may have got to know a system really well, often when systems were upgraded, they then felt that they'd lost touch of that knowledge, and they were a bit behind the times again, and obviously that just compounded the longer the time went on. And in terms of how the training or the support they got, it was often very ad hoc. So if a system was being implemented and they were there in the organisation at the time, then there'd be some learning provision. But if they came to an organisation later, or in terms of developing, it was very ad hoc. And this was really quite astounding that 93% of staff stated that digital skills weren't identified as a learning need. So they weren't recognised, identified or discussed at one-to-ones or at appraisals, and that felt quite stark, or quite it felt an important point, considering that, you know, we touch digital and use digital all the time at work now. So yeah. And often what staff said was that they're just expected to know, so they'll come into work and it's often there's an assumption that they know what they're doing, or if they're doing a job and realise that they need to use a piece of software, and it wasn't always necessarily clinical systems, they just learn to use it in the here and now, often, rather than being a bit more, I suppose, having a bit more foresight and thinking about that. And when I asked them, how did you best learn, staff said, you know, they did do e-learning, but they often didn't learn that way. The best way of learning how to use something was in practice, and it was usually when they looked over people's shoulders and saw others doing it through trial and error. People talked about feeling safer learning to use systems in test patients or in sand pits, you know, so they're not going to harm anybody, or in the moment. And I think what was really important is that, you know, how do we get people to move beyond that which button to click and that translation of system use in practice, you know, and something that works for them? Because I think generally what happens is that we put these systems in, and once they're in and switched on, is that staff are basically left to crack on and develop their own ways of working with the system in practice. And one pharmacist actually described it as a solo sport, which felt quite a strong thing to say, but actually I understood what they meant by that. It's how we've always developed our clinical practice. We observe, we spend time with people, and, you know, we have autonomy and develop clinical practice ordinarily by ourselves to our own natural style, and that's I suppose rolled over in terms of how we do that with digital. And it was just quite an interesting insight. But I think the other key thing just to point out is the NHS and obviously HE have created a whole host of resources, including a capabilities framework there, alongside a load of resources to support staff development. And unfortunately, staff weren't aware of them and hadn't used them. Next slide, please. So I think the key recommendation that came out of this was in and around making sure that we embed digital knowledge and skills into staff development plans. So it's about recognising that they're actually a thing, and that we need to help people identify and then support them, and put the support and resource in place to enable that. Next slide, please. So the next theme was in and around change, and this was really fascinating. So I think everybody across the board basically recognised change and a resistance to change as being the key barrier to digital, realising benefits of digital in healthcare. And I think if we think about change in the face of change, often one of the biggest feelings associated with that is fear, and we have a fixed mindset often. So staff talked a lot about not being good with computers, being a child of the 80s and not having access to computers at school, and I can't do computers, it's not something I'm good at. It was that kind of thing. And actually, you know, we've either worked for somebody that feels like that, with that fixed mindset. We may well be that person, or we might line manage people. You know, actually, how do we help people with that change? And I think one of the statements that summarised it very well was this one here. This individual said, we need to get better at helping people through the change, to feel empowered in the change. That change in role that digital brings, what are we actually here for? And I think that really summed it up. And I think when it comes to change, what we do is we focus all of our efforts, resource and energy on those practical aspects of change. But what we don't help people with is that psychological change. And that's called a transition, the psychological shift, and work by a chap called Bridges has been fundamental, I think, in certainly for me, in really getting to grips. It really resonates with this change that we see with digital in terms of that psychological shift. And I think just to give you a flavour of the scale of change for individuals when you put that kit in, I did research about 8 to 9 years ago in how pharmacists learned to work with EP systems in practice, and it explored, I suppose, we knew that there were changes for people, but we couldn't really articulate what that was, and it kind of gave us some insight into that. And it caused a fundamental shift across all pharmacists' professional working practices and their sense of being. Next slide, please. So, you know, we put these systems in place. We go from paper to electronic. You can just change to the next slide, please. Thank you. And what happens is that we have a change in task. We also have a change, it changed what we do, but it also changes how we do it. It changed how we were seen in the clinical environment. So people talked about losing the power of the green pen. It changed how we communicated with our pharmacy colleagues, with the wider MDT, and importantly with our patients. So a lot of people said that they felt they were talking to patients less. You know, and people inherited roles, and a lot of them didn't want them. So overnight, pharmacists suddenly became seen as experts in this electronic prescribing system. You know, and they thought, well, that's not what I signed up for. I didn't do this at university. So, you know, absolutely massive fundamental changes for people in the face of this. Next slide, please. And I think, sorry, Steph, are we running out of time?
Hi, Angela.
Yeah,
we've got 1 minute left.
Okay, so I think probably if I just finish this, is that okay?
Yeah. That's
so I think just to finish that, I think how that translates in practice is that because we all come with our individual experiences and education, it means what we see as the output, we're interpreting this individually, we end up with variation in practice. So that was the key from that, and I think the main recommendation was about making sure we put the infrastructure and support in place to support staff with change. So there was a little chat about innovation, but yeah, we can leave it there for today.
No, that's fine. I feel really bad that we have to stop now. But there are, I think your presentation has actually brought a lot of food for thought about digital skills and whether we're enabling staff and empowering them, but also how we deliver digital changes. So one of the questions that someone asked was about change management as well as training resources. How would you manage a new change or implementing a new system? The ways that we're going about it obviously is bringing more problems and brings more disempowerment for our staff and eventually our patients. So how would you go about bringing in a new change?
I think that, you know, what I described earlier in and around how we manage change is really important. So I think we need that framework in terms of that planning. So the planning that we currently do in terms of when we implement these systems, I think is absolutely a key starting point. But I think what we need to recognise is that when you do plan change, emergent change comes out of that, and emergent change is iterative. It occurs in the moment. You know, effectively, this is people creating their own ways of working is effectively this emergent change. So, you know, while people, what I would actually, there is a slide in here that kind of shows that. So ordinarily what we do is we put the system in an implementation, we plug it in, and what we want to do is let it settle in and see how that goes for 6 to 12 months to understand how it works effectively in our organisation. And then 6 to 12 months later, what we do is then think, oh, actually, everybody's doing things differently. Let's try and streamline this. Let's do the transformation. Let's redesign work processes and workflows. But the problem with that is that individuals have already done this initial, you know, how do I work with this? How does this translate for me? There's been a load of innovation gone on in those first few weeks after implementation, where people have learned to work with the system on their own. And what we need to be doing is doing that rather than a solo sport, make it more of a team sport and put the infrastructure in place, I think, in those early weeks and months to really capture that creativity, because that's when it's at its height, not 6 to 12 months later. So that all needs to happen early doors, and we don't have the resource currently, and that's not certainly how we currently do it. So there's loads of tools and mechanisms and ways of doing that, because I think if you leave it, which is generally what tends to happen to 6 to 12 months down the line, people are really wedded to their way. And then if you're trying to get people to change practice at that point. You're in the realms of behaviour change, which is really hard. So yeah, hopefully that answers the question. We're at 2 o'clock.
I think it does. Yeah, we're at 2 o'clock. I wish we had more time. There are lots of questions in the chat. So I think for everybody else who's asked questions, our speakers will answer questions afterwards, and we'll aim to put it on our future NHS site within 1 to 2 weeks. Please continue to answer questions. But thank you, Angela, for a really insightful presentation and talk. So we're just going to round off today's masterclass. I just want to thank everybody for attending today's masterclass and holding off while we've overrun a little bit. So we can move to the next slide, please. Next slide. More. Yeah. And next slide. Oh, more. Yes, okay, so just to let everyone know that the next masterclass is on the 9th of November at the same time slot between 1 to 2, and there'll be more information to follow. And just to say thank you to all our delegates who's listened to me over the past year. This is my last masterclass, and so I'm going to be handing over to Sangeeta Singh, who is a new clinical fellow in the digital and interoperable medicines team. So she'll be with you for the next year, and here's Sangeeta on the screen now. So yes, I just want to thank everyone for attending today's meeting and hanging on. I know we've overrun by a couple of minutes. And if there are any volunteers of anybody who wants to speak or present anything, please email Sarah Black on that email address. Also, please continue the conversation. I think we've had a really great masterclass today. So continue the conversation using the hashtag ePrescribing Masterclass on Twitter and on LinkedIn. And please join our learning network.
I know you've wrapped up, but on behalf of the programme, as we are finishing, can I just thank you for your commitment throughout the year. What a great job you've done, and thank you for joining us today to hand over. So greatly appreciated. Apologies, I did think you'd finished then. But...
Thank you. And I just want to say thank you to Chris, thank you to Anne, thank you to the team, thank you to everyone who's had me for the past year, and thank you for all of you for listening to me this past year. And yes, all the slides will be shared afterwards, and please join the NHS Future site and the Medicines Optimisation Digital Learning Network. All the resources, all the recordings will be available there. There is also a community of practice with lots of forums for people to get involved in. So please take part and continue to join the conversation after this session. Okay. So I think that's it. Thank you everyone for this October's masterclass. Thank you. Bye.